we will talk about management of a woman presenting with low abdominal pain in pregnancy. In other words, we will talk about possible preterm labor and some of its differential diagnosis. The common causes of low abdominal pain in late pregnancy are preterm labor, placental abruption, round ligament pain or UTI, or non-obstetric causes like ovarian cysts, fibroid degenerations, bowel pathology, or even dissection of aorta, even sometimes pneumonias. All of them can mimic abdominal pain, but commonly these are the three most common things apart from urinary tract infection. The incidence is roughly in preterm labor is around 10% of babies who are born here in Sri Lanka are preterm. It is the leading cause for perinatal morbidity and mortality and long-term disability. Worldwide, about 15 million babies are born preterm. We are placed here with regard to preterm and low birth weight here. We have 11 cases per 100 live births coming with preterm labor. Compared to Pakistan, we are better, which has 16, but compared to Japan, which has 6, we are not that great. In USA, premature birth and low birth weight accounts for the large number of neonatal deaths. Roughly about 23% of neonatal deaths are due to the preterm labor or preterm delivery. So you can see even in advanced societies, it is a big issue. So what is the definition of preterm labor and how can we differentiate it from the other causes which we discussed earlier? It is defined as labor process starting after 24 weeks but before 37 weeks of gestation. After 37 weeks it is called normal labor. Before 24 it's called abortion. It has to have clinically documented 3 to 4 per 10 minutes contractions. Membranes must be ruptured and membranes may be intact but cervix more than 2 centimeters dilated. Effacement of the cervix is more than 80%. Any ultrasound evidence of cervical length shortening, effacement or dilatation should be there. So if we classify preterm births, it can be classified into 3 main categories: early, moderate and mild. And extreme preterms are those who are falling between 24 to 27 weeks and 6 days. The mild category accounts for about 30 to 50% majority of preterm births, and most of them have fairly good outcomes if we provide the basic measures for managing a preterm birth. Extreme preterm births can have long-term and short-term adverse outcomes and are the most difficult to manage. So they usually present with non-specific symptoms like uterine cramps, backaches, increased vaginal discharge or show. As I mentioned earlier, the differential diagnoses include abruption and UTI plus other things. The diagnosis is usually to be taken very carefully, and because if we take the diagnosis of preterm labor in incorrect way, we will be putting the mother and the baby into unnecessary interventions and a lot of psychological morbidity. So always you look for palpable regular uterine contractions, more than 1 in 10. Cervical length should be less than 2, dilatation more than 2 centimeters, change in dilatation in 4 hours more than 1 centimeter. If those are there, generally you can confidently say that the woman is laboring. And if the woman is having threatened preterm labor, you can always measure the cervical length by transvaginal scan. I don't think you need to know the technique, but that can show the change of cervical length over the time and will be very useful. If you don't have any neonatal facilities at your station, any cervical length less than 20 millimeters should need you to consider transfer into a place with facilities. So this table summarizes the cervical length risk from and preterm labor or preterm birth. If the cervical length is more than 30 millimeters, the risk of delivery within 48 hours is 1.9%, very low. Delivery within 2 days is 2.8, low. If the cervical length is less than 15 millimeters, your chance of delivery within 48 hours is 36, almost 37%, and risk of delivery within 1 week is 56. Still, majority will go on to deliver term. So the risks of prematurity, I'm going into detail, but neonatal respiratory distress, periventricular hemorrhage, necrotizing enterocolitis, fetal neonatal infections, bronchopulmonary dysplasias, PDA, so patent ductus arteriosus. Those are the common problems with prematurity, and usually your neonatal lectures will cover all these topics and the basics of management. What are the causes and what are the risk factors for preterm labor? Risk factors can be categorized on the patient's history, maternal demographics, and nutritional status and physical activity. Those are the three broad categories. So if the woman has preterm birth previously, any cervical surgery like cone biopsy or large loop excision of transformation zone, multiple dilatations and evacuations, it's forcible dilatation of the cervix, any uterine abnormality, all of them will have a higher chance of preterm birth, mainly due to cervical effects. If the mother is under 17 years or more than 35 years, young primies or multis or older mothers, both of them have higher risk. Poorly educated single mothers, social poor mothers, short interpregnancy intervals, drug abuse, physical abuse, problems with cultural adjustments, all these are risk factors. And BMI is less than 19 or BMI is pre-pregnancy weight less than 50 are all risk factors for this. This is one area where you can use to counsel young women who are very low in weight. You can warn them that they can have a risk of preterm birth. Get poor nutrition state, long working hours, hard physical labor like standing or shift work, or standing for more than 8 hours. Those are all risk factors. And during the pregnancy, current pregnancy, IVF pregnancies, multiple pregnancies, fetal disorders, chromosomal anomalies, structural defects, all of them predispose. Any first trimester or second trimester vaginal bleeding, abruption, placenta previous, hypertension, diabetes or asthmatic mothers, any surgery during pregnancy, stress and depression, smoking, drug use, and infections like chlamydia, gonorrhea, trichomoniasis, or any other intrauterine infections or severe viral infections, all of them, especially with fever, they are causative factors for preterm labor. Short cervical length, fetal fibronectin being present, and uterine contractions. Those are all causes. Then how does it start? Usually preterm labor and delivery is actually the final common pathway of 4 interrelated pathogenic processes. One is premature activation of maternal fetal hypothalamic-pituitary adrenal axis. The other one is inflammation and infection. The other one is residual hemorrhage, and the last one is pathological uterine distension. So any hypothalamic-pituitary ovarian axis, if it is prematurely activated, which is sometimes triggered by placental insufficiency or maternal stress, it will increase the secretion of ACTH from the fetal adrenal, and it in return increase the cortisol secretion, which in turn results in corticotrophin releasing hormone from the fetus, which ultimately increases the secretion of prostaglandins, which induce cervical change and preterm labor and contractions. So this is the common pathway of preterm labor. Amniotic fluid infections again causes contractions, cervical length, rupture of membranes by increasing the protease activity and increasing due to increase in the interleukins. Any residual hemorrhage again triggers of extravasation of clotting factors. They causes the increase of thrombin, which can induce contractions from the uterine muscles, as well as activate various matrix metalloproteinases, MMPs, which will trigger the breaking down of the membranes and changing the cervical length. So all of them again trigger. Any abdominal trend distension triggers prostaglandin synthesis and sometimes activate myometrium, again will result in contractions and cervical change. Any residual hemorrhage from abruption again can cause retroplacental hematomas, and they can trigger usually by activating various clotting factors, and then through thrombin they can have bleeding. So how do we diagnose preterm labor? It's a clinical diagnosis. Usually the patient will come with menstrual-like crampy pain, low backache, irregular contractions, sensation of pressure in the lower vagina, spotting or mucus discharge or blood stain should be there. And your history and examination should include review of the previous history, past history or past present obstetric history, medical history, and any presence or absence of risk factors for preterm birth. And since it is triggered by multiple underlying complications like abruptions or infections, other conditions like appendicitis, bowel obstructions, pyelonephritis, cholecystitis and pneumonias has to be considered in your differential diagnosis. And all of these cases might come with other symptoms and signs, so it will be helpful in differentiating which is the real cause for which is the underlying cause. Apart from the preterm labor, there may be other telltale signs of, say, cholecystitis or pyelonephritis, which will help you to identify the real underlying reason. And sometimes any woman who is coming with abdominal pain and backache, we might disregard other symptoms and classify them as either gastroenteritis or UTI without thinking that it is possibly preterm labor. So you have to have a very high index of suspicion to pick up preterm labor. Then after history taking, you need to assess the gestational age, which you can go by going through the previous records as well as getting ultrasound scan arranged if it is not done already. And while you are doing the ultrasound scan, always do a biometry to assess the gestational age as well as estimated fetal weight. And then check for other signs and symptoms of mother like temperatures, fevers, uterine tenderness, heart rate, respiratory rate to rule out any sepsis which is underlying. And then check the contraction frequency, intensity and duration, and check the firmness or tenderness of the uterus and presentation of the fetus as well as its position. And then your speculum examination, you will see the cervix dilating. If it is more than 3 centimeters, it supports a diagnosis of preterm labor. And then if there's any bleeding, you can see it. You can exclude the placenta previa or abruption by looking at any bleeding coming through those. And then check whether there's any premature rupture of membrane, which usually accompanies preterm labor often. And if you are taking swabs for bacterial vaginosis or any other infection as well as fetal fibronectin, you can do the swabbing at the same time. Usually fetal fibronectin swab is rotated in the posterior fornix for about 10 seconds. Then we should, if after excluding any placenta previa or any active bleeding and rupture of membranes, you might be able to do a digital cervical examination or to assess the cervix, cervical dilatation and length. And sometimes you may see that the cervix is in the middle, it is compressed, in both ends it is opening up with a hourglass-like appearance, which is a key feature to suggest cervical insufficiency. And then you can confirm those things with transvaginal scan, and before 34 weeks, if the length is less than 30 millimeters, it is usually an indicator of predictive of preterm labor. And if it is more than 30 millimeters or 3 centimeters after 34 weeks, it has a fairly high negative predictive value for preterm birth. And cervical length knowledge will actually improve your management as well as avoid unnecessary hospitalization and interventions. Sometimes you may have to couple with transabdominal scan to confirm the fetal presentation, assess the amniotic fluid volume, estimate the fetal weight. Any placental and or uterine abdominal anatomies can be identified. So it is still useful to do both vaginal as well as abdominal. And then after information is gathered, you can use to counsel the patient. Sometimes it is better for you to get the neonatal team to come and counsel the woman. Then out of the laboratory investigations, commonest thing that we do is beta group B streptococcus culture, as well as if there's any discharge, we might take a high vaginal or endocervical swab. Any urine cultures should look for any asymptomatic bacteriuria. And if you suspect any drug abuse like cocaine or methamphetamine, you can use, which are cause for placental abruption, you can use a sample of urine or blood for confirmation. And if you want, you can do fetal fibronectin. Usually it is done below 34 weeks. Any STDs, if it is suspected, can be tested. Then we come to the predictive ability of preterm labor. Why do we need to predict? Because only 50% of the women who develop preterm labor will go to deliver before term, and the other 50% will deliver at term. So if you can identify the people who are really going into preterm labor, it is very easy to focus our attention and treatments. Otherwise, we will be subjecting almost every woman who is having some abdominal pain to treatments and interventions which are sometimes dangerous and can even increase the risk of preterm labor. So methods to predict are multiple, like scoring systems, CRH measurements, cervical length, fibronectins, qualitative as well as quantitative fibronectin tests, cervicovaginal interleukins, or combined transvaginal cervicovaginal fibronectin markers in the form of app which is called QUIPP, which is being used in most of the European countries now, and salivary trial or any signs of bacterial vaginosis, which are known risk factors for preterm labor. So this lists common risk factors, some of which I have given earlier. Okay, so you need to check them in your history, and then you can do a cervicovaginal sampling with the posterior fornix swab test. And the fetal fibronectin is actually a extracellular matrix protein which binds the membranes to the maternal decidua. So it's a kind of a glue-like molecule. So if the glue up to 21 weeks of pregnancy, appearance of fibronectin is normal, because at that time the cervix is being formed. So there's a problem with attachment and this separation of the membranes from the cervical and uterine tissues, and they can escape into the vaginal fluid. But by 21 weeks this process is over and membranes are tightly attached. After that, seeing any separation of membranes will release fibronectin into the cervicovaginal fluid and can be an indicator of preterm labor. So you can measure it quantitatively or qualitatively. Qualitatively, it will tell whether it is present or not, and then that will give you a rough idea whether the woman is likely to go into preterm labor or not. but the accuracy is much more improved if you can measure it quantitatively and incorporate that with other data. So doing fetal fibronectin alone probably is not enough. So if the fibronectin is positive, within 7 days you can attribute it to a positive preterm labor. And its predictive ability is here. Within 7 to 10 days, sensitivity is 76%, under 34 weeks 69% predictive value, under 37 weeks 60%, and sometimes negative predictive value is more because you can rule out preterm labor. So every woman who is having pain, if it is negative, you can reassure them the chance of preterm delivery is less. False positive results of fibronectin can happen if you have had intercourse and ejaculate is there, any blood stain discharge or specimen, and vaginal examination or digital cervical examination or even a transvaginal scan probe might release some of the fibronectin. So it might give a false positive. Any lubricants, medications or washing with douching chemicals are implicated in false negative or false positive reports. Quantitative fetal fibronectin is better because it gives better predictive value, and rather than giving one-off qualitative test, it depends on the amount of fetal fibronectin in the vaginal fluid, and it has a higher predictive value of delivery under 34 weeks compared to one-off qualitative test. So all these quantitative fibronectin are bundled with other demographic factors which are found from other risk factors, and they have calculated combined risk using an app called QUIPP App. It is available online. You can download. It has two formats. One is for asymptomatic women with the possibility and calculate their preterm labor risk, or symptomatic women. And then after inputting all these risk factors, it will tell while including the cervical length as well as fibronectin results, it will tell whether your chance of delivery within next 48 hours is high or not. So it's a very useful app and you should try and use it. Unfortunately, we don't have a way of getting quantitative fibronectin test, but we can always measure the cervical length. Still, it is useful. Then after going through the clinical criteria and after looking at the membranes, you have patients who are diagnosed as preterm labor. Some of them will have uterine contraction, some of them will have cervical dilatation, some of them will have shorter cervix, some of them will have intermediate cervix plus positive fetal fibronectin. So the management depends on the POA actually and other risk factors which you have found. If the cervix is dilated more than 3 centimeters, you need to think that it is preterm delivery is likely and try to stop the contraction till you finish the magnesium sulphate as well as dexamethasone. If there's possibility of GBS infection, you give antibiotics and magnesium sulphate for neuroprotection until about 34 weeks. You can give from about 24 weeks. And any antenatal steroids you need to give. If the dilatation is less than 3 centimeters and fibronectin is positive, again the preterm birth is likely. But if preterm fibronectin is negative, it is unlikely, and then you can observe and then discharge them to come back in about 2 weeks or so. If the gestational age is more than 34 weeks, usually we will admit for delivery, and sometimes we will consider giving steroids. And if the cervical length is more than 30 millimeters, again unlikely to go for delivery. If you want, you can confirm that with the fibronectin and do it later. The twin pregnancies, in twin pregnancies, cervical length will be the one which usually help you to diagnose, and generally they have higher chance of preterm labor. And over 34 weeks, you triage them according to the cervical length, like in preterm labors or singletons. If it is less than 34 weeks, you might need cervical length plus fibronectin. And what is the treatment? I have already mentioned. You need to admit, give complete steroids, give tocolysis in the form of nifedipine, take GBS swabs, magnesium sulphate for dural protection of the fetus, and broad spectrum antibiotics, especially if membranes are ruptured. But if with intact membranes, there's no point giving antibiotics. In acute preterm labor, no point giving progesterone supplementation. But if it is a woman who has had a previous history and has a higher risk of preterm labor, probably progesterone supplementation has a place. Outcome depends on your ability to stop the contractions with tocolysis, as well as your ability to give steroids and magnesium sulphate. And if woman goes into delivery, whether we can influence the prognosis is actually very difficult to predict. And if there are any triaminated infections or any growth restriction, then those things also will impact on the outcome. Right. Next thing is whether we can prevent any preterm labor. One way is to reduce the risk factors which can cause preterm labor. So putting circlages on multiple pregnancies. It is not indicated up to twin, but triplets or more probably will still get that circlage. And treating for bacterial vaginosis, screening and treating probably is a good option. In cases where we have had previous preterm births, we might even treat them even if they have candida infection, because candida still causes a biofilm formation on the vagina. On top of that, other organisms like bacterial vaginosis can thrive. So to prevent that, we might even vigorously treat even candida infections in women with previous history of preterm birth. The treatment for bacterial vaginosis is metronidazole cream or clindamycin cream. Circlage, very tricky decision, because it might actually, since it's an invasive procedure, might trigger uterine contraction and worsen the risk of miscarriage, preterm delivery. So when you are putting a circlage, you have to make sure that the woman is really likely to go into preterm labor. And the only way to do that probably is to measure the cervix from early pregnancy and then target the circlage only in women who are having evidence of shortening. Then how do we stop the preterm labor? We use tocolysis. Idea is to suppress contractility of the myometrium, delay and prevent it as much as possible, and get time to administer steroids. Every day which you keep the baby inside increases survival chance by 1%, so it's fairly useful. So we have various drugs, beta-mimetic, cyclitrodrine and salbutamol, calcium channel blockers, Magsalv, indomethacin like oxygenase inhibitors, antagonists for oxytocin, nitric oxide donors, progesterone, vaginal or IM can be used. Tocolysis is generally done to either to buy time for steroids or delay delivery till transfer. It is not indicated in cases of abruptions, infections, maternal hypertension, any congenital abnormalities, advanced labor with cervical dilatation, or any signs of eclampsia or fetal compromise. And usually after 34 weeks we won't stop. With nifedipine, it is actually normal release or standard release nifedipine. You can use it 20 mg orally and then 10 mg half hourly until contraction ceases. Maximum of 40 mg can be given. You can give up to 48 hours. But unfortunately, we have only nifedipine SR, slow release, which is not really suitable. So most of the time we use 20 mg SR BD, which is probably a suboptimal dose, but some benefit is there. Using nifedipine is contraindicated in severe maternal cardiac diseases, women with hepatic dysfunctions, or those who are on concurrent beta sympathomimetics and antihypertensives. We don't have it in the WHO essential list in Sri Lanka, but it is included by the WHO in their list. And there's no place for maintenance therapy with nifedipine. Other supportive therapies which I have mentioned earlier include magnesium sulphate, which you give as 4 grams over 20 minutes, or 2 grams or 4 grams over 20 minutes, and 1 gram per hour until 24 hours or until delivery. And if you give only loading dose, you can it may be adequate if the delivery occurs within 4 hours of its administration. Steroids, again, if maximum benefit is only when you deliver within 24 to 7 hours to 7 days, 1 to 7 days, and it has to be given after 24 weeks up to 34, 36 weeks. And even when they have diabetes, you should be giving. In IUGR babies, even up to 36 weeks you can give. You have 2 choices, dexamethasone and betamethasone, but in our country we have dexamethasone, and you can give it 6 milligram IM for 48 hours. Or if you want, you can give even 12 milligrams IM 24 hours, but that is not the recommended dose. If you are on insulin, you might have to be watchful about the control within the next 2-3 days after administration. And repeat administration or routine repeat doses is not recommended. Sometimes after giving dexamethasone, if the preterm birth is going to happen, does not happen within 7 days, and if it is coming up in later time, you may have to give a rescue dose up to about maximum of course 4 courses can be considered. If it is not stoppable, you need to balance the risk of keeping the baby inside as well against the risk of delivering the baby. And then you should know about the factors which influence fetal baby well-being, maturity of the gestation of the baby, maternal condition, parental wish, and availability of neonatal care expertise to handle. And always confirm the gestational age, recognize maternal infection in illnesses which are coexisting, establish fetal live presentation, calculate the weight, assess the fetal well-being by Dopplers, CTGs, as well as volumes and biophysical profiles, do a speculum and vaginal examination if it is progressing, inform your seniors, plan for steroids, tocolysis, Magsalf, and get the pediatric neonatal team informed and plan for facilities, as well as ask them to come and meet the parents and counsel about the possibilities and possible managements in future. Vaginal delivery is preferred to reduce the maternal morbidity than delivery by cesarean. If the maternal obstetric history is complicated, any time delay between induction and delivery, and if your chance of vaginal delivery is less, then probably or abnormal presentation, you may have to consider giving for a cesarean section. If it is non-cephalic, usually you should go for cesarean section. If you are delivering vaginally, you may have to be careful about rapid progress, and episiotomy and epidural anesthesia as well as should be available, and neonatal team should be there to deliver. Delayed cord clamping is usual, and if you are going to deliver by cesarean, you have to deliver the baby with the sac completely, and call deliveries to prevent the trauma on the baby. And sometimes we may have to have a vertical incision on the lower segment because the uterine lower segment is not well formed at preterm gestations. Postnatally, mother should be given option to see the baby, get the pediatricians to inform the baby's progress to the mother, or if it is not, you should, as obstetric team, look after the mother and inform her about the baby. You need to counsel them about at least interval of 12 months after delivery for next pregnancy, give dietary advice, allow a postnatal visit, and do a debriefing. And if the baby dies, you have to be very careful of handling that case. In preterm, prevention of preterm birth in multiple pregnancies, I have touched on it earlier. Sometimes we opt for prostaglandins or progestogens as well as circlages, but none of them have proven effects on preventing preterm labor. Now we move on to the other coupled coexisting condition, which is called preterm pre-labor rupture membranes, and it is managed in the same way, and almost all the issues which are there applicable for preterm labor are applicable here. The only thing is you need to confirm the dates, note the date and time of onset or dribbling, do a gentle sterile Speculum examination, and avoid any vaginal discharge. And every day do a full blood count and CRP if it is possible, and then take high vaginal endocervical swabs for gram staining, for bacterial vaginosis, as well as GBS screening. Chart the pulse, temperature, FHS every 4 hourly, assess the presentation and exclude any cold presentation, and assess lycovolume. Same as preterm labor, DEXA, magnesium sulphate, and then your delivery mode you need to decide. Tocolysis is considered only when delivery is imminent, if you want to buy time till the DEXA is over. Usually we start with erythromycin, but each unit should actually give your own choice of antibiotics, because there's widespread resistance to erythromycin. If there's any infection, if there's temperature, check them for abdominal tenderness, check for any offensive lico, any cloudiness on the lico. Lico normally is clear, but if it is cloudy, it is suspicious. If it is meconium stain, again it is suspicious of infection. And then usually in our unit we start cefuroxime and metronidazole, and then if not possible to deliver in your place, then the patient goes to a place where it is possible and available with neonatal facilities. If you are going to manage them conservatively, always do regular twice weekly or weekly scans for lico and biophysical profiling, check for Doppler blood flows and CTGs at least daily till the delivery. Any woman who is having any dribbling, usually we deliver them by 34 to 37 weeks. Depending on the unit and the facilities available, your hospital might have different policies. If there's any question, you can raise them in the comments, and please follow at least one patient properly with the history examination and management during your THO appointments in the professorial unit. Thank you.